Welcome to Legacy Therapy, the podcast that will teach you, in bite-sized chunks, how to leave a stress-free legacy so loved ones can focus on people, not paperwork, when you become ill or pass away. Here is your host and financial advocate, Stacey Golden-Lisnock.
Hello, and welcome to the 7th episode of Legacy Therapy, planning techniques for a stress-free legacy. And I'm excited today because we have a special guest and we have a topic that I don't think many people really know about really well, or if they do, they don't really understand it very well. I have Samantha Trad with us, and she is the California State Director for Compassion and Choices. Samantha passionately works hard to expand patient-centered and patient-directed end-of-life care across the state. She's an expert on implementing medical aid in dying laws, and leads education and outreach efforts in California to eliminate barriers for eligible patients who want the option of medical aid in dying under the California End-of-Life Option Act. Previously, Samantha taught American politics at the University of Redlands and was the executive director of the Arizona Advocacy Network. Samantha has a BA in political science from the University of Redlands and a master's in international economic and political studies from Charles University in Prague, the Czech Republic. In her free time, if she has the free time, Samantha loves spending time with her family, running, hiking, and is an all-around outdoor lover. And she's based in Redlands, California. So welcome, Samantha.
Stacey, thanks for having me.
This is an interesting topic. I happen to hear you do one of your outreach webinars. And so I reached out to see if you could come on and kind of educate people here. So legacy therapy, we're really looking at finding ways to leave a stress-free legacy for our families. And I know that there's a way with this compassion and dying conversation that can happen for families, where a person makes that decision. And now with the law changing in California, it's actually legal. I'm old enough to know about that whole thing with Kevorkian and all that. And he was trying to help people in this very way when it was illegal, right? So can you talk to that about how this all started, and just give us some insight and some experience in how families actually handle these kinds of decisions? Because I know we usually don't want to let people go, but if it's their choice, maybe it's a little easier. I'm not sure.
Absolutely. So Oregon was the first state to pass a medical aid in dying law back in the 90s. And I remember it because I was actually raised by a mother who was terminally ill. And I remember when everything was happening with Oregon, we talked about whether or not this would be an option for my mom. And I remember just being shocked that we didn't have that option available to us in California. And we even talked about moving to Oregon, but I was in high school and my dad's work was here and my mom's doctors were all here in California. And so we decided that even if things got really bad, we weren't going to move to Oregon. And it was heartbreaking that my mom wasn't going to have the full range of end-of-life options available to her. And the last thing she wanted was a long, painful death. And thankfully, we were incredibly lucky. My mother received an organ transplant at UCLA and lived, actually. She's actually still alive today, and that was over 20 years ago.
Oh, well, now that in of itself is fabulous. Oh my gosh, what a great story. Okay.
Yeah. But it is something I think about a lot, because from my earliest memory, my mom was sick and she was in pain and she didn't want to suffer. And I think there's a lot of people like that. There are people who believe in redemptive suffering and want a suffering, and that's fine if that's their choice. But for people who don't want to suffer, it's really important that they have other options available to them and that they know what those options are. A lot of people don't realize what the options are. So Oregon, over 20 years ago, implemented a law, and there's no physician assistance in it. In order to access the law, you need to be terminally ill with a prognosis of 6 months or less to live. You need to be mentally capable, which means you can't have advanced dementia. So this is not something that you put in an advanced healthcare directive. It's something that you have to be capable of understanding, and you take the medication yourself. You have to be able to self-ingest the aid in dying medication on your own. Now, if you can't swallow, the majority of people who use medical aid in dying usually drink it, but there are other options. So if you have a feeding tube, as long as you're the person who pushes the plunger, or you can use an anal catheter. And again, as long as you're the one who you're capable of ingesting the medication yourself, then this is an option for you if you live where it's authorized. So Oregon was the first state. Today, over 20 years later, there are 9 states in Washington, D.C. have all authorized similar medical aid in dying laws, with the exception of Montana. Their law is from a state Supreme Court decision. And California authorized medical aid in dying. The law passed in 2015, and it went into effect in June 2016. In fact, it went into effect the day before my mom's birthday. She was born on June 10th. So it's easy for me to remember that date. And we know from the data, we have data for the first 3.5 years from the Department of Health that nearly 2,000 prescriptions have been written. Now, it's really opened the doors for a lot of people to be able to talk to their doctors and to have the end-of-life experience that they want. Many of you may remember the name Brittany Menard. She was a young woman who shared her story back in 2013. She was 29 years old, had a horrible form of brain cancer, and lived in California. And she knew the trajectory that her disease was going to take her down, and she did not want to die that way. So her and her husband, Dan Diaz, moved to Oregon so that she could access Oregon's medical aid in dying law. But that's not something she wanted to do, and that's not something she wanted other people to have to do. That's not how she wanted to spend her final months and weeks of her life. So she advocated for medical aid in dying, and in fact, she helped convince Governor Brown to sign California's medical aid in dying law and pass the law here in California so that we can have that option as well. So it's been a long road, and we continue to legislate for medical aid in dying laws across the country. California was the 5th state to authorize medical aid in dying. But what's become clear is that it can still be very difficult to access for a lot of people. The most important part of accessing medical aid in dying, there's actually a 12+ step process in order to obtain the medication. You can't just ask your doctor for it and pick it up the next day. There's a mandatory minimum 15-day waiting period that a terminally ill person has to go through before they can get the medication. And we do know that about 1/3 of eligible patients don't survive that waiting period. So it's really important to talk to your doctor as soon as possible. You know, imagine what kind of end of life you want. What experience do you want for you and your loved ones? Do you want to be in a hospital hooked up with machines? That's how most people die. But it's not how most people want to die. And right. I think that's a huge part of legacy. You know, a lot of people remember the last time they see their loved ones alive. And when you are able to control that end of life experience and die on your terms, you know, there's a lot of people who have parties, or they just have a few close relatives who are with them when they take their medication. And it's so incredibly beautiful and moving, and a gift for you and your loved ones to be able to experience if that's what you want, you know, and if you qualify for the medication. Right. And there are other end of life options as well outside of medical aid in dying for people that, you know, a lot of people don't realize exist and are out there.
Yeah. What kinds of things are those?
So another end of life option, it's called voluntarily stopping eating and drinking. And when I first heard of it, it sounded terrible because I have awful hangerness. I hate being hungry, right? That sounds awful. Who wants to voluntarily stop eating and drinking?
Right.
However, when you're sick and you're dying, your body starts naturally shutting down. And we kind of have this strange idea that the compassionate thing to do is to force feed people, to flick down their throat, which may not be what they actually want. Right. And so that's why it's important to have these conversations with your loved ones. Maybe when your body starts shutting down, the compassionate thing to do, maybe the thing you want your loved ones to do, is to make sure you're comfortable. There's medication you can take to make sure you're comfortable. And then don't force the food, don't force drinking, and let the person die naturally that way.
Sorry, but is that something that you can have in your healthcare directive?
Yes,
okay.
That is absolutely. And in fact, on our website, we have an addendum in case of dementia. And a lot of people who are worried about becoming demented or having advanced dementia, having Alzheimer's, they want the option of voluntarily stopping eating and drinking. They want their pain to be managed, but they want their loved ones to withhold food and drink at a certain stage. You know, there's actually a couple of stages of dementia. But, you know, again, it's something to think through. And we have Finish Strong tools. They're called Finish Strong tools. And it's a little quiz where you think through, like, okay, if I seem happy, but I don't recognize my loved ones, you know, do I want to refuse treatment if I get pneumonia? Because that's another end of life option. Is simply refusing treatment is actually an end of life option that we don't think about, right? We kind of live in this culture where death is seen as failure. But, you know, are we all failing at the end? I don't think so, right? It's, you know, maybe having a tragic death is the failure. So you may want to not treat certain diseases at certain stages of dementia, you know, but again, like maybe if you seem happy, even though you don't recognize your loved ones, you can't control your bodily functions, maybe you want to treat that disease, right? Everybody's different. But it's really important to think through all of those things and then write them down, share them with your loved ones. And in California, you do need to have 2 different witnesses sign your advanced healthcare directive so that it can be upheld. And having a proxy, somebody to advocate for you when you can no longer advocate for yourself, is so important. And I know talking about death is really difficult. None of us want to imagine our loved ones dying. But if we don't have those conversations, it's not going to stop them from dying, but it may lead to an end-of-life experience that's hard on everybody. And I think that's a huge part of legacy.
Yes, I know. I've been through a few and found it really interesting that a person that is in a coma, or, you know, like they are not taking food or drink or anything like that, that they can actually live from somewhere, is it like 5 to 11 days or something like that?
Yeah.
Just without food and drink. And from what I was told, and these were all seniors, you know, they were older, is that seniors are generally dehydrated. They're living in a dehydrated body. They're not hydrated like you or I. So you or I would never last 5 or 11 days with no food or water. Mm-hmm. So, you know, that's kind of something else too. And so when you're sitting by the bedside of somebody and you're sitting there and you know there's no hope, but I mean, what are you going to do? There's nothing more that you can do in that type of situation, right? You just let nature take its course. So what is the religious side of the whole thing, where maybe they look at it like it's suicide if they take this medication? What goes on with that?
Well, again, this is why it's so important to think and reflect about what you want, and then make sure your loved ones know, because for many people, maybe they do want to be force fed. They do want that liquid. And if that's their end of life wish, that is what they should have. So the biggest opponent to medical aid in dying is the Catholic Church. But what's interesting is if you poll Catholics themselves, they tend to poll at the same rate as everybody else. They still want the option of medical aid in dying. But the Catholic doctrine is very clear that this is against the Catholic faith. They do consider it to be suicide, which is really unfortunate, because I think a lot of people, even Brittany Menard, talked about how it was offensive to call it suicide. She did not want to die. She wanted to live, but her terminal illness robbed her of her life. So she decided that she just didn't want to die tragically the way her disease had planned for her. Instead, she wanted a little bit of control over something she had no control over. And suicide obviously is a really important subject that does need to be dealt with, but it's very different from what medical aid in dying is. I think it's really important to know where you go for healthcare is extremely important. So for example, we know that 97% of hospitals across California that are religious do not allow doctors to practice the full range of end-of-life medicine. So for example, if you're at Dignity Health, it's a large healthcare system that's Catholic. You cannot have the full range of end-of-life medicine because doctors are not allowed to practice it. Adventist hospitals as well. There's a young woman named Amanda Viegas who I know and love, who had her husband was at a religious hospital, and he was 29 years old, like Brittany Menard, had a horrible form of bladder cancer, and had watched his grandma die from actually the same rare form of bladder cancer a few years earlier. His grandmother had raised him, and he did not want to die the way she did. It was awful. She was in so much pain, and he knew he wanted medical aid in dying if they could not find a way to beat his cancer. So when it became clear that nothing was going to work and it was time to plan for the end, he asked his doctors for the option of medical aid in dying, and they weren't allowed to help him because they were at a religious facility. So he enrolled in a hospice, and the hospice there also wouldn't help him. And he had the most horrendous death. And his wife is a photographer, and she photographed his end of life experience because she didn't want anyone else to go through the same thing he did. And we actually did a webinar on September 3rd with her, where she shows her pictures and talks about that experience. And it's so incredibly moving. And I encourage you, if you go to our website, you can find the webinar and watch it. But her story is really important to tell. And, you know, if the number one thing I hope people get out of our time together today, listening to this, is talk to your doctor now. Even if you're not sick, talk to your doctor and ask them, you know, if you were to become terminally ill, and if you think you might want the option of medical aid in dying, ask your doctor if they would write that prescription for you if you qualified. I'm pretty healthy. I'm very grateful, knock on wood, I'm very healthy, but I've had that conversation with my doctor, and he was shocked. No one had ever had that kind of conversation with him before. And he had to think about it. You know, he'd never helped someone or, you know, prescribed medical aid in dying before. And he realized that he would absolutely do it. You know, if that's what I wanted and I qualified and I was terminally ill and dying already, he would absolutely prescribe medical aid in dying to me. And I was really glad, because I'm a really busy woman and I didn't want to have to find a new doctor. Right. That's an important value issue for me personally, that my doctor truly listens to me and respects me and will support my decisions. So I encourage everybody, you know, talk to your doctor and ask them if they'll support you in your end of life option. Even if you're young and healthy, you never know what's going to happen, especially in the world we're living in right now. It's so important to have these conversations.
Yeah. And what is the website where they could actually go see that webinar? So
our website is compassionandchoices.org. And I think it's on our homepage, but if it's not on our homepage, if you click on, I believe it's Take Action, you can find our Staying Stronger webinar series. And we have a lot of webinars. In fact, we actually have a legacy and end of life wealth planning webinar coming up in a few weeks. That your listeners might be interested in. I'll send it to you after.
Okay, great. That was pretty interesting. I wanted to ask you, it just came to my mind, like, so when people decide that they're going to do this and their doctors approve of it and they actually have the medications in their hand, like, are there people that decide not to do it after all, or how does that work?
Yes. It's really interesting because we see the same statistic in all of the states that have authorized medical aid in dying. About 1/3 of the patients who go through the whole process and get their medication never actually take it. And the reason for this is they have it on hand just in case, just in case their suffering becomes unbearable. I'll never forget a man I met who told me he never felt more alive than the moment he got his aid in dying medication. And he said he knew that sounded totally bonkers, but it gave him a new lease on life. He didn't have to worry anymore about what was going to happen because he had this option available to him in his home that he could take if he needed to. And he also said he hoped he never had to take it. He did not want to take his aid in dying medication. He didn't want to die. But again, his terminal illness had taken the option of life away from him. And he was so grateful just to have it. There's a woman who's one of our storytellers named Julie Stroud, who lives in Berkeley, and her dad was a philosopher and a philosophy professor at UC Berkeley. and he had aid in dying medication. He was terminally ill, and every day he would ask his daughters to show him where the medication was. And he said, okay, I have it. Today's not the day. And it was so interesting to her because, you know, he was a philosopher. So for him, it was like this idea of what is quality of life? Like how far can I go without taking my medication? You know, is it going to be when I can no longer control my bowels? Is it going to be, you know, this and this? And he ended up never taking his medication. And she was shocked because he, you know, it was something he knew he wanted to have, but he never got to the point where he felt like he needed to take it. Instead, he felt comfortable letting his disease take its course.
Yeah.
And their whole family is just so grateful he had that option. It was freeing, you know, it's this freedom of having options that you can decide whether or not to take them. So just having that option can be huge for people, even if they decide not to take it.
Right. I definitely can see that because you're out of control, right? You don't really have control. This gives you one thing that you could control. And so you get the choice. So I guess that's where you have compassion and choice. So two things came to mind. How much is this cost for this medication? And is it covered by your insurance or whatever? And then in the cases where they aren't taking it, that's a lethal dose that it shouldn't be just hanging around somewhere. Like, what happens to it if it's not you?
Great questions. So first of all, you know, people always ask that question, what happens to the medication if they don't take it? You got to remember, these are terminally ill people who have a lot of lethal medications at home already. And so their doctors and their pharmacists will have counseled them on what to do with those medications. So there are locations where their families can return the medication, or they'll talk to them on the phone and tell them how to safely discard the medication. And, you know, in over 20 years of having aid in dying medication authorization across the country, there's never been a single incident of coercion or abuse in any of the states. It's never been a problem. You know, you got to remember, again, these are terminally ill people who have those lethal medications already at home. And then the question about cost is such an important question. So unfortunately, in the 90s, Congress passed a federal funding restriction on they call it assisted suicide, which again, it's not suicide like we talked about, and it's not assisted either. Right. But unfortunately, Medicare cannot cover medical aid in dying. And the vast majority of people who use aid in dying medication are in fact on Medicare. And so this is a big problem, and it is something that our organization is working on to try to figure out how to remove this restriction, because Medicare needs to be able to cover this cost. In California, we're very lucky because Medicaid or Medi-Cal does cover aid in dying medication, and most private health insurance also cover aid in dying medication, as well as the consultations to receive the medication. So it can be a problem. I also do a lot of work in Hawaii. I joke I have the best job at the organization. I'm the Hawaii State Director and the California State Director. But actually just this last week, a doctor reached out to us because she has a patient who's terminally ill, would qualify for aid in dying medication, but can't afford it. She gets $800 a month and that's it. The medication itself usually runs around $300 to $400. And then the consultations, again, are usually covered by insurance. And so, you know, we're trying to figure out what to do with this patient. And the doctor said, you know, if worse comes to worse, I'll try to help her for free, but you can't do that in every case. So it is a problem, making sure people can afford the medication and afford the consultations.
Is that something where like a nonprofit could potentially like provide the funds? I mean, that doesn't sound like a lot of money. I thought you were going to say more like $5,000 or something like that. So
yeah, thankfully it doesn't cost that much.
Mm-hmm.
Actually, when California first authorized medical aid in dying, the most common aid in dying medication went from about $400 to $5,000. It was horrible what they did. And they said, oh, it has nothing to do with California authorizing, but of course, you know, it probably did. But there are different grants and community groups that might be able to help. In fact, what's happened, the latest news in Hawaii is we found a foundation that helps cover costs at end of life. So we're seeing if they're going to be able to help this woman pay for her health care at end of life. So, it's a case by case situation. I actually don't know of any in California. And it's not something we do at Compassion and Choices. But we do try to make sure that when we work to pass aid in dying medication laws, that Medicaid will cover and that private health insurances will cover. So a lot of people will either pay out of pocket. I've actually never seen it for aid in dying, but there's GoFundMes that come up for different issues all the time.
Right.
And then, finding health insurance that'll cover it, private health insurance.
Yeah. Now, since it's not like you said, there's been 2,000 prescriptions written, right? Is that in California or in total?
In California. And that's from June of 2016 through December 31st, 2019. So there's probably been 2,500 or more prescriptions written today.
Okay. So since it's a fairly small amount compared to what drug companies would, if you're going to be making Tylenol or something, you're making millions and gazillions of them. So is it a special order thing, or is it on the shelf, or are there many different pharmaceuticals that are doing it? I'm just kind of interested to know about that.
Yeah, that's all great questions. So there's, like anything else, the actual prescription depends on the illness, what the person has, and there are several different aid in dying medications available. But the most common one right now actually has to be made at a compounding pharmacy. And so we do keep a list of pharmacies. We don't keep a list of doctors for a lot of reasons, but we do have a list of pharmacies that will fill prescriptions. And in California, you can have the prescription mailed to you. So for example, if there's, a doctor listening or a patient who's interested in this, they can tell their doctor this. We have something called Doc to Doc. It's a free confidential consultation line that doctors can call or email. And we can let you know where the closest pharmacy is where you can fill an aid in dying prescription, as well as the latest aid in dying medication protocols that exist. We have a wonderful medical director named Dr. David Grube, who is usually the one that you talk to if you call Doc to Doc. If not him, it'll be another doctor who has a lot of experience with aid in dying medication.
Yeah.
And the whole process.
Is this anything like what they use like in the death penalty? Or totally different?
They don't know. It's different from that. The most common medication you drink, you usually fall asleep within 5 to 15 minutes. And then depending on, what's happening with your body, you usually pass away. I've heard as quickly as within 5 minutes after falling asleep, but sometimes it can take up to 2 hours for the person to pass away. But for the person's experience, you fall asleep and you don't wake up.
Mm-hmm. Yeah. Well, that's what a lot of people want to do, right? They want to die while they're sleeping. That's what everybody says. It's like, yep, I want to just die when I'm sleeping.
Yeah.
So yeah, this has been fascinating. I really, really appreciate you coming on. And I'm hoping that our listeners are as interested in this as I've been, because this is something there aren't very many experts on it. And hasn't been around for very long. And, hopefully no one listening needs to use this service, but it is available now in California. It's not illegal any longer. And we're just coming around as a state, sort slowly but surely, on all these different things. So again, I appreciate you coming. So is there any last things you would like to just kind of reiterate, like how they can get a hold of you, how they can get more literature, what your outreach is, if you're doing webinars for organizations, or what your outreach really is?
Absolutely. Yeah. So we're on Facebook. We have a national Compassion and Choices Facebook page, as well as a California Facebook. We're on Twitter. You can go to our website and sign up to get our emails, which I highly recommend. We're really active. I mean, we do so much education and outreach at Compassion and Choices. And I think there's going to be some exciting things coming up in California over the next couple of months and years. And, I would say the most important thing, again, is talk to your doctor, talk to your family. If you're not sure what you want at the end of life, go to our website. We have so many different tools. You can try to think through what your values are at end of life, what you want. Make sure you have that advanced healthcare directive. We do presentations on putting together advanced healthcare directive. We do presentations on, what is dementia? What are the different stages of dementia? So all of those things you can find on our website.
And again, that was
Compassionandchoices.org. Yeah, compassionandchoices.org.
Okay, great. All righty. Well, I certainly, again, thank you so much for coming on, and thank you to the listeners for listening to this episode. And as always, I like to refer you back to the website that I have going on, www.gotittogethernow.com. And you will see there that we have our online course all laid out. And this is definitely one of the things that you would be discussing with yourself and your family when you're putting together your healthcare directive and your advanced healthcare, all of that stuff. That's in module 1, because I have that all up front. Very important, because you never know when you're going to get in an accident or have an illness hit you or something. And then that's not the time to start investigating and having the discussions around these topics, because they're just too important to have to rush through them. But they're so important that you do need to get to them. So I'm finding there's a little bit of a catch-22 there with not urgent, but important. So I'm going to leave it with that. So I'm signing off. This is Stacey Golden-Lisnock, your financial advocate. And until our next episode, take care and be safe out there. Take care. Bye-bye.
Thanks, Stacey.
Thank you.
Thank you for listening to the Legacy Therapy Podcast. If we hit it out of the park today and you learned at least one new thing to take action on in your own quest to planning the best legacy possible, then be sure to tell your friends, subscribe, and rate and review wherever you get your podcast. The show notes will provide the sites and information that were discussed today. You can get more great tips, resources, and inspiration by visiting our website, legacytherapypodcast.com.